Very good morning to all of you. On behalf of Department of Conservative Dentistry and Endodontics, VSPM's Dental College and Research Center, Nagpur, I welcome you to eLink Fest 2020. We would be having webinars daily for the entire month of July, 1 hour, 1 month. Today, on 20th day, we are privileged to have alumni of VSPM, a young and a dynamic speaker, Dr. Azhar Ali, who would be speaking on the topic of cracked tooth diagnosis, treatment planning, and literature appraisal. Today, we are also honored to have a stalwart in the field of endodontics, Dr. Mandeep Grewal sir, as the moderator for the scientific session. A warm welcome to all the participants of live session on our Facebook page, Endocons VSPM Nagpur, and it's a kind request to all of you to put up your queries on Facebook page. Now, I take this opportunity to introduce our moderator for today, Dr. Mandeep Grewal. Sir completed his bachelor's from SDN College of Dental Sciences, Dharwad, and his master's from A.B. Shetty Memorial Institute of Dental Sciences, Bangalore. He has been head of department and postgraduate guide since year of 2008. He has numerous publications of national and international repute to his credit. He is also reviewer board member of various reputed specialty journals. As a skilled clinician, his special interests include aesthetic dentistry and endodontics with inclination towards use of dental operating microscope for the last 10 years of his practice. He is a great academician with over 20 years of teaching experience and currently the Dean of the Faculty Dental Sciences, SGT University, Gurugram. Now I request Dr. Mandeep Grewal sir to introduce our illustrious speaker for today, Dr. Azhar Ali.
Good morning, everyone. It's an honor to be here today, and I must congratulate Dr. Shenoy for putting this up, this educational fest that she's organized, she and her team have organized. I'd like to introduce Dr. Azhar Ali, who's done his post-graduation from CDER AIMS. He's also alumni of VSPM Dental College. He was a senior resident in AIMS soon after his postgraduate degree and is currently working as a specialist endodontist at Ministry of Health in Saudi Arabia. The topic he's chosen today is of extreme importance to us because cracked teeth have suddenly increased in their incidences, and managing them is a real challenge. So I'd like to invite Dr. Azhar Ali to take over and let us know everything that is to be known about the cracked tooth. Dr. Azhar.
Hello everyone, good morning. I take this opportunity to thank Dr. Shenoy ma'am for organizing an amazing extravaganza of knowledgeful 1 month of complete knowledge on endodontics and conservative field. I also take this opportunity to thank Dr. Mandeep Grewal for his kind words and supporting me in my upcoming venture. So let me begin by a small introduction of myself. I am Dr. Azhar Ali. I hail from Nagpur. I did my BDS in the year 2005 from VSPM Dental College, and this is my college, and this is the department which I've worked for, given my 5 years in it, and it has provided me with the basic knowledge and skills. To that I owe most of my, I thank my professors and teachers for providing us with the necessary skill set to, go forward and achieve our career goals. The next thing which I would like to thank is our department at CDER AIMS under the able guidance of Dr. Professor Ajay Logani sir and Professor Naseem Shah ma'am. Whatever I am today is because of these departments, and this is my current hospital where I am working at Saudi Arabia. It is a specialist dental It is the specialist hospital, and along with it, a attached dental center is there. Currently, I am positioned in this hospital. Okay, so after seeing this photograph, you will somewhere relate to a incident when whatever you are enjoying a sumptuous meal or a hearty meal with your friends, having a good time. When you are enjoying a meal, suddenly you note or you find that something terrible, an electric shock, some sort of a foreign body, you will hit on the tooth, and there is a sudden pain in your teeth. This incidents will, keep keep you reminding the fact that these type of incidents have risen nowadays because of our changing eating habits, and these type of pains have led to some terrible headaches, maybe orofacial pains, and the patient thinks that something definitely is wrong with me. And what is wrong with him, even he does not know, because the pain does not locate to the tooth itself. Okay. Now, if this scenario, the doctors usually come across these type of cases, and if this type of scenario happens in your OPD, you will be perfectly aware what do you mean by a cracked tooth, or how to get around with the cracked tooth. But if it hasn't happened with you yet, I think the day is not far when this type of case will come into your OPD, and you will be surprised to know what a cracked tooth can give a patient, what type of trouble. So here's my topic of today is the cracked tooth, its diagnosis, the management, and the literature appraisal. So this topic is a bit small topic, and you will find it to be given in our endodontic textbook in just small paragraphs. But believe me, it has much to offer, lot much to be discussed and researched about. So I will try to cover this topic under the following headings. What are the cracked teeth? How are they different from other type of teeth fractures? And what are the factors leading to a cracked tooth? Which symptoms and signs we have to look out for, how to locate the extent of the crack, and once the crack has been found out, we need to decide about its management and prognosis. So what are the cracked teeth? Now, about the definition of the cracked tooth, initially many anecdotal terminologies were put around by the clinicians and the researchers. It was initially known as a cuspal fracture odontalgia, a green stick fracture, or incomplete tooth fracture, and later it was named as a cracked tooth syndrome. Now, when you find my slides, you will always see a word cracked teeth, not a cracked tooth syndrome. The reason for that I will tell you in the upcoming slides, which is based on the symptoms. Okay. For now, we will suffice with the definition of the cracked tooth. It is an incomplete fracture initiated from the crown and extending subgingivally, usually in the mesiodistal direction. And this definition has been provided by the American Association of Endodontists. Now you have to notice 2 points here. It initiates from the crown and it extends subgingivally. Okay, these are the main factors which has led to the troublesome management and the prognosis of the cracked tooth. Now, what is the difference between a crack and a fracture? You will ask that the fracture is also same as the crack, but I will like to tell you that crack is always an incomplete, and hence in the definition you will find the first word as an incomplete. You need to understand that the fracture has a complete shear force which connects both ends of the object. But in a crack, there is only one side of the object which has suffered an infarction as opposed to a fracture. So we need to understand that cracks are different from fractures. Now, what are different type of fractures and what is a basic cracked tooth, how it is different from other type of infarctions? So if you find the classification which has been provided in the textbooks, the cracked tooth comes under the category of longitudinal tooth fractures, longitudinal tooth infarctions. Okay. So as you can see in the first diagram, it is known as the cusp fracture, in which area of the tooth which has been sheared off by the forces, and you can find that the whole segment of the area of the tooth has been connected with the fracture line. So this is a complete fracture, as opposed to a cracked tooth, in which you can see that there is incomplete extension of the fracture line, which does not pass through any of the sides or any of the walls of the tooth, making it complete. Okay. Same is the case of split tooth, but in which the split tooth has a complete shear. It is connected to the outer side of the tooth, giving the tooth a splitting mechanism, having, fractured both the sides. And as we have discussed in the definition of the cracked tooth, it originates from the crown and extends to the apex. But in the case of a VRF or a vertical root fracture, it is the opposite. It originates from the apex and runs towards the crown. So the topic for today is a cracked tooth. So my discussion is focused on the cracked tooth itself. These cusp fractures, longitudinal split tooth and VRF are not in for our scope today. So now, we have learned the definition, now let's see what are the factors which are mainly responsible for a cracked tooth. I am trying to present this seminar in a way in which most of the audience, like most of the postgraduate students or most of the general practitioners, would relate to. I don't want to go into the depths and details of each and every point, because I want to give everyone an idea about the, the aspects of the cracked tooth. May it be a specialist from a different field, a prosthodontist or a periodontist, or maybe a general practitioner. So I will try to present this seminar in a way that everybody, relates. Now we will see the factors which are responsible for a cracked tooth. Now you have to understand the fact that the tooth itself that may have some problem with its development or some morphological factors, but always remember the factor which is responsible is the excessive force. The excessive force which gets concentrated in the specific areas of the tooth is the most important factor. Now whatever factors you are seeing on the slides are the factors which tries to concentrate the force in a specific area of the tooth, leading to a strain or a shear force, which ultimately gives tooth the crack. Okay. So the restorative procedures which I will like to highlight is the over preparation, over contourings, the occlusal MOD cavities which render the tooth susceptible to fracture. Occlusal fractures, one of the main factor is the masticatory accident, in which you might find a pit of a cherry while biting a cake, or having a nut, something like that, which suddenly gives you a shocking type of pain that might lead to a cracked tooth. The most important point here to highlight is parafunctional habits like bruxism. As Dr. Mandeep Grewal said in the introduction, that these type of cases are on the rise. One of the main factor for the rise of these cases is stress. The stress and the parafunctional habits nowadays are providing us with cases in which there are actually no restorative, procedures done, no morphological abnormalities. Everything is fine, but the patient presents with the cracked teeth. This is because of the parafunctional bruxism habits. We need to understand the fact that the stress is the most important factor, specifically in times like these when we all are under the lockdown period. We have to remember that these type of habits do play a role in the rise of these cracked teeth, or maybe the cases of a VRF in untreated teeth. Okay. So I will like to comment one point on the steep cuspal angles and thermal cycling. Now, what the steep cuspal inclines of the maxillary molars may do, you can see whenever there is excessive force due to the steep cuspal inclines, there is shear stress on the areas of the tooth which might concentrate on the deep pits and fissures of the opposing tooth, leading to the crack or fracture in the mandibular molars. Now, one point more about thermal cycling. Now, what do you see in this graph? There are two types of graphs you can see on this slide. This slide I have made from the article which has been published in Journal of Endodontics in 2014. It states the effect of thermal stresses on mechanism of tooth pain. Now, what type of effect does thermal stresses do? Now, these type of stresses, you will come to see that these generate shear stresses like tensile and compressive stresses. Now, how? On the graph D, you will see that that is effect of loading, hot loading, and on the graph E, you will note that it is having effect of cold loading. Now, hot loading means that temperature of 60 degrees centigrade was applied on the surface of the tooth for 1 second. And cold loading means that a temperature of 0 degree centigrade was applied on the surface of the tooth for 1 second. Now you will see the temperature and the timelines on the y and the x-axis respectively. The black represents the temperature change and the red represents the stress and the strain or the stress change in that area. Now at the room temperature, that the body temperature, when there is effect of hot loading, you will find that there is sudden increase in the stresses. That red graph, it suddenly increases to the value of 700. It is plotted on the negative axis. Why? Because it is inducing compressive stresses on that. And this on the cold loading, it is plotted on the positive axis. The values are in the positive size of the stress. Why? Because they are generating tensile stress. Tensile is the pulling force. Compressive is the, by the name suggests, it's a compressive force. Okay. So what happens whenever you apply 60 degrees centigrade for one second on the tooth, you can see the time taken for the temperature to rise is from 37 to 37.8 degrees centigrade in around 20 seconds. Okay. But whenever you see the red stress graph, it states that the stresses develop within 1 second and they again come to the normal. It goes from the compressive and tensile just within 1 second. So this is the range of the time in which so much stresses, about 700 kilopascals in hot loading and about 1200 kilopascals in cold loading develop. Now, as we all know that tooth is a brittle material. It cannot stretch, it cannot compress as we see like a resilient material. Okay. So enamel more brittle than dentine because of its inorganic nature. So imagine these type of stresses whenever you have anything hot or anything cold, these type of stresses developing, and these type of stresses lead to the formation of micro cracks. These micro cracks ultimately, due to the constant thermal cycling, maybe mechanical forces, develop ultimately into the crack, and the following symptoms occur. So now just let's rewind it. What we have seen till now, we have seen that there are different type of longitudinal tooth fractures. Cracked teeth is one of the most common longitudinal tooth fracture, and the etiology is the excessive force. A crack or a fracture is always a finding. It is not a diagnosis. Okay, a diagnosis is a pulp and a periapical disease. We should be in a position to establish a pulp and a periapical diagnosis to form and strategize a treatment plan for the patient. Now, coming upon the criteria of symptoms, what are the type of symptoms that you can see that the patient presents to you with? The most common symptom which has been given in the literature and which has been told by the patient is pain on chewing. As simple it is, whenever you bite, there will be pain. That's how the patient recognizes that something is wrong with his tooth. Okay. Now, what is the percentage of patients having these type of pain? It was found out in a study in the Australian Dental Journal in 2009 by Dr. Paul Abbott and his team, that the pain experienced by the patient was 68% of the patient experienced the pain on biting. Okay. And there are some cases when there was no pain on biting. The 9% of the cases showed that they did not have any pain. So these type of symptoms, uh, there is not a specific line of symptoms which you will find in a syndrome. What is a syndrome? A syndrome is a type of etymology in which there are specific types of symptoms present, and hence we name it as a syndrome. But cracked tooth syndrome, I will again like to emphasize, is a wrong terminology. We have to remove the word syndrome from it, because cracked teeth presents with vague symptoms. Always it is subjective. Patients may have pain, may not have pain. Patients may have different type of autonomic symptoms with these type of cases. We can see in the further slides. I will try to tell those type of symptoms also. Now, what is the cause of the pain? It has been supported by the hydrodynamic theory of Brainstorm, that there is movement of the dentinal fluids. In early stages, we all know that it activates the A delta fibers, which are myelinated in the pulp, and hence we can recognize, oh, there might be a pain in this, because myelinated fibers have a sense of proprioception. We can locate the tooth. But maybe in future, what happens, because of the more inflammation, there is a chance of activation of unmyelinated fibers, which give a vague sense of location. The patient is not able to locate his pain. Now, pain on cold stimulus. This cold stimulus elevated response is why? Because when there is a crack present, of course it is a microscopic crack, but it is a highway for the bacteria. It is a big avenue for the bacteria to lodge themselves. Whenever you are unable to clean that area because the bristles of the brush can't go there, this bacteria colonies, they form biofilms, as you can see in the slide, which I have shown. It is taken from the Journal of Endodontics 2015. So many bacterial biofilms are lodged into the dentinal tubules, and this bacteria and their byproducts will will sensitize the pulp. This sensitization of the pulp leads to the early response to the cold stimulus first. Now, now in one of the studies in 2017, it was found out the pain to the cold was the most common symptom associated with the symptomatic cracked tooth. Although often considered as the most reliable diagnostic tool for the cracked tooth is the pain on the biting, which we have first seen, the bite pain. But this study at 2017, it is from the National Dental Practice Based Research Network, which is in the USA. They have associated the type of pain, the level of the cracks, and the tooth and the patient level characteristics in posterior teeth with visible cracks. So they've found out that the most common symptom was pain on cold as opposed to the biting pain. You can see the 63% cases have been having pain on cold as opposed to the 26% cases just on the bite pain. So there are many changing trends in this research. We need to locate specific symptoms We need to find out specific order of the criteria of the symptoms. Although pain is a subjective matter, but still uh, the research keeps on changing, and we need to stress the point that whatever we believe right now may be not true. Now, whenever the pain is long standing and the crack is long standing, it will obviously lead to the bacterial lodgement, their metabolic byproducts, and the toxins. Now, what does this do? What does the bacteria and the toxins do is they sensitize the pulpal C fibers. After the sensitization of the C fibers, it is the threshold of the pain and the cold stimulus is lowered down further. Okay, and this leads to the hyperalgesia, prolonged pain, and this prolonged and spontaneous pain gives you a sensation of headaches. The headaches which have, in my experience, which I have seen with patients, that the patients were so much in trouble that they were not able to sleep, not able to enjoy their food, and some patients, or maybe one or two, needed psychiatric counseling. This type of cases leads to so much diffuse and protracted pain. As you can see in the in the table, the time in which patient presents prior to seeing the endodontist, it ranges from 1 month to the period of 12 months, maybe 1 to 3 years, of more than 5 years. So the patient keeps on going to a doctor, to another doctor, so that someone will give him medicine, or someone will try to tell him that he is okay, he's not having problem with his brain, everything is normal. Patient keeps on going from one doctor to another doctor because of the symptoms of his uh, pain. He is not able to locate the pain. The teeth are giving him pain, like mimicking of trigeminal neuralgias, ipsilateral facial pain, and autonomic symptoms like the numbness on the tongue, numbness on the upper lip, maybe excessive salivation from that area, sometimes having teary eyes, lacrimal secretions are more in that area. These type of symptoms have been seen, and we need to make sure that we report these type of symptoms. We need to take account of these symptoms, and we need to help these type of patients. And how do we help them? Because we have to know that what a cracked tooth, long-standing cracked tooth, can give a patient. These type of discomforts have been experienced by the patient, and whenever you try to tell them, they think that the doctor must be joking or something, because they don't believe that a small cracked tooth or a small tooth can give them so much of headaches. So the main point here highlighting is, please take the histories properly. Please consider, be empathy, keep empathy towards your patients. And these type of symptoms, whenever you treat them, whenever you try to help those patients, you will be like a superhero to them, because the patient might be thinking that I am having some problem with my brain, I'm having some tumor or something, but you tell them ultimately that it is a small cracked tooth. So you are a superhero for him. Just keep these things in mind. Now, superficial cracks. Superficial cracks will lead to reversible pulpitis, because the reversible pulpitis is because of the inflammation and the bacteria. And as on the similar lines, whenever the crack goes deep inside towards the pulp or the pulp chamber, it will give you irreversible pulpitis because of the heavy bacterial colonization. You can see on the slides so much bacterial colonization in the dental tubules adjacent to the crack. So now let's revise the fact. What is the location of the crack? The more central the location of the crack, the deeper it tends to be. because if the crack is not located centrally, it is away or maybe on the buccal or the lingual side, it will try to shear off from the wall, the outer wall. So it might give you a fractured cusp, okay, but not the crack tooth. The crack tooth centered, and the more the center of the location of the crack, the deeper it is. Now when the extent is deep, it will try to involve the pulp. Whenever the most of the pulp tissue is involved, it will give you different type of, or maybe a symptom of, initially it will give you a symptom of reversible pulpitis. Then again, if it is deeper, it will give you a symptom of irreversible pulpitis. So therefore the extent of the crack is determined by its location and the symptoms are determined by the extent. Now, what signs do we need to look out for? What objective tests which we can do to make sure that there is a presence of the crack? So the clinical examination goes in this order. First is the inspection. The inspection will be done in the following steps. Then there is percussion. Then there are bite tests, and there are radiographs. We will discuss that these type of aids are not so much of help in the crack tooth because of the factors of the parallelism and the resolution. So the radiographs are not much of a help in these cases, but yes, it might give you some proxy points which you can relate with the crack tooth. Now inspection. Under the dental operating microscope, with the aid of dye staining, maybe a methylene blue dye, you can find the presence of a crack. The recommended magnification for this is between 12x to 16 or 18x. Okay, whenever you're using a microscope, you need to make sure that there is proper illumination, proper centering of the focus beam of the microscope, and you will ultimately uh, locate and find the extent of the crack, which extends, maybe extending beyond the confines of the pulp chamber into the root canal orifices. In these two photographs, you can very well see that the dye staining has rendered the crack, and here without dye staining, only the blood line, the blood which was there in the pulp, this can be seen in the outer distal wall of the pulp chamber. Now, second step is transillumination. This is a step which is done to carried out before operating these inspection steps. Just we need to make sure that what type, like where is the location of the, just to locate the crack. Now the principle behind transillumination is whenever an incident light passes through a material which is having its integrity, it courses through the material without any disturbance. But whenever there is a crack in the object, what happens is the incident ray of light enters into the crack, and there is air inside the crack. The light is scattered by this crack. It does not traverse accordingly into the same line. So it is scattered, which renders the object dark. You can see in this area, this whole area is having the same congruent material. The light is passing through it. Now this is a crack. This crack has air inside it, which scatters the beam. That's why this area appears a little bit dark. So this is called as a day and night effect. This point we should always remember. You can use the handpiece light, or you can use the light cure light which is available with due precautions for your eyes. This will help you to locate the presence of the crack. Now coming to the percussion tests. Percussion can be in the vertical and horizontal directions. The vertical percussion will tell you that which cusp or which cusps are involved in the crack, and the horizontal percussion, which will tell you about the periodontal status of the tooth, which might have a, or which supposed to have a crack. For percussion, you can use a tooth sleuth or a fract finder. These are commercial devices which are available, which focuses your forces on a specific cusp. So whenever you ask the patient to bite over a tooth sleuth, it tries to separate only one cusp from that. So then you can realize that this area, or maybe distal, or maybe the distobuccal or distolingual, or maybe mesiolingual is having a crack inside, like is hiding a crack inside that area. Now there is aspect of periodontal probing. By this aspect we can find out if there is a crack which is, as we have seen in the definition, it extends subgingivally. Till what limit or what extent it has done the damage for the bone and the attachment levels. So a plastic probe is recommended because it can bend and pass through the narrow pockets which are present. In this type of condition, generally a narrow pocket is present because there is not generalized inflammation in that area. Adjacent to the crack, the presence of the bacteria and the toxic products leads to the degradation of the bone level, which is in a thin and narrow fashion, not in a broad fashion as compared to the generalized periodontitis. So we need to remember that fact that a metallic probe might not enter that area properly. Okay, a metallic probe having the rigidity might not enter that area. So you need to pick a plastic probe which can bend and which can blanch the tissue. The plastic probes are a bit wider than the metallic probes. In that area, when you try to insert the plastic probe, it will blanch that tissue, and you will come to see that this pocket is deep and it is a tight pocket in a long standing cracked tooth. Of course, uh, an early phase of the cracked teeth, you might not find any of the periodontal attachment loss, but yes, in the later the long standing cracked teeth, you may find sinuses, multiple sinuses, uh, maybe attachment bone loss in that specific area adjacent to the crack. So these are the proxy measures which you can find to which you can locate the crack in that area subgingivally. This one, a bite test. A bite test is a type of test in which you will encounter rebound pain. Now, what is a rebound pain? Rebound pain is the pain in which when the patient bites, there is a pain, but when he opens the bite again, then there is pain. Why there is pain? This is because of the uh, movement of the dental fluid. Again, when the patient bites over the tooth, the fragments separate, right? Thus causing pain because of the movement of the dental fluid. When he relieves the bite, again the segments try to approximate. This leads to again movement in the dental fluids, which causes the rebound pain. So we need to see that are these patients having, all of the patients have rebound pain, or it is in some cases. So what we found out is in the same team by Dr. Paul Abbott, their article says that on both application and release of pressure, there were 15% of cases which had rebound pain and biting pain, and only rebound pain was present in 8% of cases. So you should understand that there is no specific set of symptoms which will guarantee that this is a cracked tooth unless and until you locate it and you find the extent. Location and finding the extent is the main criteria for cracked teeth. Now radiographs, I have told you earlier, as the location of the crack is in mesiodistal direction, it is very hard for the radiographs to capture the cracks because the X-ray beam passes perpendicular to it. It does not pass parallel through it. If the X-ray beam passes perpendicular to the crack, it won't be registered. It will be just overlapped by the opposing walls of the crack of the teeth. Okay, so what you can see in this radiograph is the same tooth before excess opening cavity. There you can see that it seems seemingly normal tooth having some radiolucency here, just in this area, but you cannot make out what type of problem it might have. But yes, what you can see in the pulp chamber is a pulp stone. Now, what gives rise to a pulp stone is pulpal irritation. Now, where the pulpal irritation is coming, it is from the crack. You need to look out for these proxy measures. Maybe some periodontal bone loss, maybe a pulp stone in the pulp. These type of findings we have to be, diligent about finding these things. If you are suspecting a cracked tooth, please look out for these findings. It will help you. It will help you in registering the cases, and it will help you in further medico legal purposes. So a proxy of pulp stone and small amount of bone loss you might appreciate in this area adjacent to the crack. And CBCT, OCT, everything is there nowadays, but no proof or no basic no basic test is there to locate the crack without intervention. There is no basic test to locate the crack. Only we have to remove the tooth structure and see till what extent the crack is. Till now there is no method. Everything is under the table, under research. We need to find methods for locating the crack and improving the resolutions. As you can see in this CBCT slide, there is one area in which you can see the radiolucency mimicking this crack here. For the crack to be visible on this, it has to be very wide, and that's not the case with every every case. You will find many different type of cracks. Actually, these are types of the crack which are leading to a split tooth. So these wide cracks, if you will find, maybe there is a higher chance that there are multiple cracks extending from the same very crack, might lead to a split tooth. Okay. So let's rewind. What are the clinical signs and symptoms? Are the probing depth. We have to find in early cases it is less than 3 millimeters. Later cases maybe 9 millimeters. Bite pain mostly present. Okay, bite test you will get positive. Percussion test you will get positive, maybe negative, because there are many different methods. We might not be able to use tooth sleuth, fract finder, commercial devices. Possibility of isolation with maybe the cotton rolls and a rubber cusp plunger with it, which is available with the syringes. You can use that tools. Maybe they act as a cheaper alternatives for a fract finder or a tooth sleuth. You can use that compressible things to get a bite test out of it, positive or negative. And then vitality tests might show a normal pulp, and here you can see that most of the cases had non-vital tooth. Why? Because maybe the cases did not report earlier. They had long-standing cracked teeth, and the pulp had lost its vitality. So these are the clinical signs and symptoms we have to look out for, and there is no specific criteria. Again, I will like to stress, we should not depend upon the uh, terminologies which is given in the book. Now we have to call it only cracked teeth, not cracked tooth syndrome. Now, once you have located the crack, we need to uh, we need to see till what extent does it, what's the extent of the cracked tooth. So the instrumentation which is recommended is a small round burr initially to remove the coronal area or remove the coronal areas, and the ultrasonics in the deeper areas of the teeth. Ultrasonics and the round burr, they will do is slow removal of the tooth structure in the upper area will lead to recognition of the crack. And ultrasonics with the help of dental operating microscopes will help you in positioning your positioning your instrumentation on the specific crack area with disturbance in the visualization and the removal of the tooth structure, which is, which might happen with the unjudicious use of these burrs. So maybe a number 2 Startex ultrasonic is a very good option for removal of the tooth structure above the cracked teeth or the cracks. And maybe a number 5 Startex, which is used for finishing the pulpal floor. These two instruments I will like you to recommend to use. They will give you adequate visualization of the area under the microscope and uh, specific control over that area to remove only just that tooth structure uh, which we desire to be removed in order to locate the extent of the crack. Now, when we have located the crack, we have to realize till what depth it has entered into the tooth material, and basis on that basis we will decide its management. Okay, the management depends upon the location, the extent, and the symptoms. Now, according to the extent, when it is a superficial crack, not extending up till the chamber floor or the chamber roof. I would like to say up till the chamber roof, not the. What symptoms do the patient presents with are the symptoms of reversible pulpitis. What is our aim in this case? Our aim is to prevent irreversible pulpitis. How do we prevent the irreversible pulpitis? Is by locating the crack, ascertaining its extent, and putting a material which will help to, seal the crack. Seal in the sense it will help to seal the bacterial ingress of the crack, not the crack as a whole, but the only bacterial ingress which has been causing the symptoms of reversible pulpitis. We need to seal that. Now, how do we seal that? We seal that with present restorations, which has been documented. There has been evidence of survival of more than 3 years for resin restoration, more than 3 years, and 98% chance of survival of with these type of restorations. Second option is onlay, and the third option is full crown. Now, onlays and full crowns are, though they are invasive procedures, but what they are trying to achieve is they are preventing the pulpal ingress of the bacterial toxins, the bacteria themselves. And second thing, they are giving a splinting uh, mechanism, a splint to the teeth in order to prevent the cusps to flex. Okay, so this will try to reduce the symptoms by biting. This will give the adequate strength to the teeth in order to withstand the biting forces or the chewing forces. Okay, so onlay and full crowns are the, in my opinion, I may be wrong, but in my opinion, whatever research I have done, it seems that the onlay and the full crowns are the best options to restore a superficial crack. Now, what happens when the crack extends deep beyond the roof of the chamber, or it extends on any of the walls inside the pulp chamber, or on the any of the walls or either of the walls of the pulp chamber? So it will lead to the irreversible pulpitis. What we need to do is we need to first splint the crown, splint the tooth with the either you may use orthodontic band orthodontic band is a good option for immediate splinting of this cracked tooth. Once we have ascertained the extent, we have to use an orthodontic band which will provide you with a barrel staff effect. In a barrel, you will find when there is the log sticks are kept and it is encircled with a round metallic band. It is in order to prevent this swaying of the logs. So in same cases, we will try to splint the cracked tooth, try to splint to prevent the flexion of the cusps. And when the pulp is involved, of course, we need to do the root canal treatment followed by a full crown restoration. Again, full crown will prevent movement of the cusps and further prevention of the extension of the crack due to the occlusal forces, and it will provide a seal. Now, the importance of seal is that the tooth is the only hard tissue in the human body in which God has not given the mechanism to heal by itself. The bone heals by itself when you approximate the segments of the fractured bone, they heal by itself. But the tooth, unfortunately or fortunately, the God has not given us the mechanism to heal by itself. Okay. So we need to remember that once there is a crack in the tooth, it will always remain there. We just need to approximate the segments, give it a tight, splint so that the fragments does not move under occlusal forces. And if it is done earlier, the earlier the better. In the later stages, what happens is there is loss in the bone, the tooth becomes mobile, and ultimately the prognosis is from questionable to it becomes hopeless. So you have to remember that the prognosis for the cracked teeth is always ranging from questionable. It is not good, it is not fair, it is always questionable. Now, what happens when the crack extends inside the pulpal floor and or maybe one of the major root canal orifices? So, as I've told you earlier, the prognosis is hopeless because you cannot seal that area. There is no mechanism to seal that area yet. One thing what you can do to extend the life of the tooth is you can do an hemisection of that area. You can plan an hemisection, you can remove that root resection you can do, that's it. But still that does not have any major advantage, or the survival advantage is maybe not more than 2 years. So we have to discuss these factors with the patient, that once there is a crack, it will always remain inside the tooth, and it is up to him how does he want to go about it, and what are the factors, what are the restorative factors, what are his economical factors, what does he think. We have to take patient's advice into the patient's role into its consideration. Okay. Now in these type of cases, once the crack is extending onto the pulpal floor or into the canal orifice, you have to extract. The prognosis is hopeless. Now what you can do after extraction is you can plan an endodontic autopsy. These are high resolution photographs of the patient's tooth, in which you can see that there is the extension of the crack at 2 millimeters from the CEJ, at 4 millimeters from the CEJ, at maybe 6 to 8 millimeters from the CEJ. So now this is the tooth which is having that distal crack. You can see you can appreciate the presence of the crack, which is extending up to the 8 mm level, or maybe 6 mm level of beyond the CEJ. So imagine there will always be a bone loss whenever this tooth is there in the body. The adjacent bone loss will always be there, and ultimately what happens is the bone is rendered not proper. The bone level goes down, and that area is not rendered for the implant also. You cannot place that implant also in that area. So we have to understand the fact, the deeper the crack it goes, you have to judge for the prognosis, and you have to plan an extraction for that in order to preserve the bone for future prosthetic implants. Now, what is the prognosis of the teeth? Once you have treated the tooth, the patient might ask you, doctor, please tell me till how much time we can keep this tooth. Like, what are the chances? Should I invest in the treatment or should I go for the extraction? So, what do you advise? The patients will obviously ask you. So, this is the problem with the cracked teeth literature. There is very scarce information on the prognosis of these type of teeth, and there is no clarity on the prognosis information, which allows the clinician to judge the survival of the cracked teeth after we have done the root canal treatment. So there is one research based network in the USA. Now, there are two schools of thought about this. Once there is a location of the crack, you need to monitor or either you need to restore. One school of thought says that you need to just monitor the crack, just give them the orthodontic band, the splinting, and you need to monitor the crack. And one school of thought says that whenever the crack is located, if the patient is having mild symptoms or maybe not having symptoms, you need to restore that then and there. Okay, so we will see in this article, and it is published in 2020 Journal of Dentistry, that you will see that out of the 1850 untreated cracked teeth, over two-thirds shows no change in symptoms in the 1 year of their observation period. So they have monitored the teeth in which they have applied that orthodontic band, and they have monitored and they did not find any changes in the symptoms of the teeth with cracks. And less than 20% of the patients were recommended treatment. And you will see that no treatment, and the monitoring period of that treatment is till 1 year, and with 60 maybe 68% of the cases they were just monitored. Now this is distribution of the types of teeth in for 1 year among 1850 patients who had no treatment performed. So you will find that 37% patients and 27% patients in the year 0 and the year 1, there is decrease in the symptoms of the patient. Whenever that in that 1 year gap which they have monitored the teeth, uh, the reason which they have cited is the decrease of the symptoms, maybe because of the inflammation in the pulp has rendered them, or maybe it has increased the tolerance level of the pain for that patients. So the symptoms have decreased from 37% to 27%. Now this is an interesting finding, wherein which we were thought that we were always we were of the opinion that the symptoms will try to get worse and worse. But these type of studies which have come up right now, they have uh, led us to believe that the number of the number of symptoms might increase or might decrease. And it all depends on the number of crack lines and the time period. Now what are the survival, what are the the timelines of survival after once you have done the treatment? What is the timeline? So whenever you do a direct composite restoration, it has shown that the pulp vitality was maintained for 7 years, and I'm sorry, more than 90% of the teeth had maintained their pulp vitality after 7 years. So a direct composite restoration for a superficial crack is a good option. So you can confidently say to the patient that there is a 90% chance that your tooth may survive till 7 years. Now, teeth with bonded cuspal coverages like onlays had performed better than the teeth with non-cuspal coverages. So the main reason for this is, I told you earlier, the flexion. Whenever the bite force occurs, obviously there will be flexion. But when you provide a cuspal coverage, you will try to provide an occlusal splint, which will force the segments to be in a uh, a tight bond between them will be there, and it will prevent the flexion of the cusps. Similarly, bonded indirect resin composite onlays for painful cracked teeth have been reported a 6-year survival rate of 93%. So a bonded indirect onlay or a bonded full crown is a better option, and you can convey to the patient that you might have a chance, 93% chance of the survival of this teeth for more than, or maybe till 6 or 7 years. So what are the things which this practice-based research network suggests us to see? That do you want to monitor the tooth or you want to restore the tooth? What are the criteria to look out for? So the first criteria which they have said is the presence of the caries along with the crack. So whenever you find caries, and you have to go in the descending order of the odds ratio, which I have put up on the slide on the right, on your right hand side. First is the caries, second is the biting pain, third spontaneous pain, and the evidences of a crack on a radiograph. If there is evidence of crack on a radiograph, is better to restore it because the crack will be in wider dimension. Okay. Cold pain, and the patients who has dental insurance along with them. These were the factors which were considered for restoring the tooth having crack. Apart from the second group was monitoring. So these were the factors which were considered by the clinicians that they want to restore the cracked tooth. So first was the caries along with the crack, presence of pain, maybe biting, spontaneous cold pain, and the evidence of crack on the radiograph. The most common reason cited for restoration was the compromised tooth structure, because as we all know that removal of the because of the presence of the crack, there will be flexion in the cusps, and it will ultimately compromise the tooth structure and ultimately might lead to a split tooth, or the presence of the symptoms of sensitivity and painfulness, or presence or fractures of the restoration along with the flexion of the tooth. So the most common reason cited was the compromised tooth structure. And the most common method for restoring these type of teeth was cited as the complete full crown with indirect placement or bonding type of cementation of these type of cracked teeth. So a complete crown, you have now understood that it provides a splinting mechanism and a coverage mechanism over the crack. It covers the crack physically, as well as it splints the cusps of that area, of the crack tooth, preventing its further flexion and extension of the crack. So a complete crown in the 61% cases which you can see in this table, with bonding type of cementation, was the most recommended restorative option for these type of cases. Now, what is the prognosis of cracked teeth after the root canal treatment? And now distribution is character and survival after the root canal treatment. Okay. So which we can see is here. Here is the distribution of the cracked teeth. You can find the most common was the maxillary first molar in the maxillary arch, and mandibular second molar in the mandibular arch. Out of the 175 longitudinal tooth fractures, most common was the cracked teeth with 63.4% cases. And what you can see in this table is the characteristics of the cracked teeth. You can see that there are no filling. The patients having cracked teeth had no restoration. They were perfectly healthy teeth. Again, I would like to stress the point that, as our respected chairperson mentioned, that there is a steady rise in the incidence of cracked teeth with healthy tooth structure, no filling, no restorations. Okay, so this study congruates with it's congruent with his thought that there is a steady rise. You might find more and more cases in your OPD. We have to look out for these factors. No restoration, you can see 60%, 34.3 percentage of the cases. Similarly, there is no restoration on the opposing tooth, which is in occlusion with that cracked tooth, and there is no endodontic treatment received with that cracked tooth. Okay, so you cannot argue that we have done root canal treatment, so it has rendered the tooth, uh, susceptible to fracture. But you can see here the scenario is opposite. The teeth without root canal treatment are having more cracked teeth. See again, cavity classification. No treatment, more teeth having cracks. Class 1 cavity as opposed to class 2, which we all, think that might give a more chance of a cracked tooth because of the thinner walls. But again, class 1 cavity, you know, what this type of class 1 maybe or no restoration is suggests is that there is some other mechanism which comes into play, which delivers the forces, or maybe increases the forces to the level that the teeth are not able to handle. So we have to consider the psychological factors of stresses, bruxism, the steep cuspal inclines, and thermal cycling. Please take a note of these factors and discuss with the patients along with their histories what might come into play, what different, a cocktail of factors might be there which can lead to the type of fractures in the non-treated category of these cases. So again, most commonly the treatment rendered for the symptomatic cracked teeth was the root canal treatment. You can see the root canal treatment was done in the 77 cases, 44 percentage to be exact, in these type of teeth. And the most important factor which came out to be associated with the survival, 2-year survival of the cracked tooth, was the probing depth. The attachment loss, if it is less than 6 mm, there is 96.8 percentage of chance of survival, of 2-year survival rate of these type of cracked teeth. And whenever there is more than 6 mm of probing depth or attachment loss, the chances of survival decreases to 74% after till 2 years. Okay, so this was the most common fact we need to understand. We have to discuss with our periodontist friends also, that having these type of teeth, having these type of complications, what will be our treatment protocol, what treatment strategy can we devise, because the crack, it will be always be there in the tooth until and unless the tooth is there in the body. We have to understand that the crack having more than 6 mm periodontal bone loss does not have a good prognosis. Till now, the research is still here, and hopefully we might find some mechanisms to counter this, to increase the survival rate, and maybe to prevent the cracked tooth. The most important thing in any disease to cure is for lowering its potential is to prevent the disease, not the cure of disease. So we need to understand the factors which leads to the cracked teeth. We need to discuss the factors, how to prevent those factors. Like suppose if there is bruxism, we need to provide the patient with a night guard. We need to make him recognize that he is having bruxism. The patients, they don't know only that they might have the habit of bruxism until unless they go for proper examination, The doctor sees the wear facets over the teeth. So ultimately, we have come to the end of the presentation. Now I will like to present some suggestions from my side, which may help in developing long-term, treatment protocols and increase the prognosis of these type of teeth. Are first is we should try and endeavor and establish networking among clinicians. The tertiary institutes should come and play help with, and established research and sample provisions should be established. There should be a central registry of cases among the networks to keep regular follow-ups of the cohorts. And the research methods, especially the technical advancements for early detection of the cracks, should be done. And we need to propose the predictable long-term treatment protocols for this perplexing condition. Now, again, the last slide points to remember cracked teeth. They are on the rise on healthy molar teeth. Factors the causing cracked teeth should be considered, and they should be discussed with the patients. Careful interpretation of the patient history and meticulous testing ascertains the extent of the crack, and evidence-based knowledge should be imparted, and regarding treatment and the prognosis helps in achieving the predictable results. Thank you, everyone, and be safe. That's about it. Thank you.
Thank you. It was really a great presentation, Dr. Azhar. It has given us a detailed insight about the concept of crack teeth, a truly informative session. So now I
I tried
request,
my humble efforts. Thank you.
thank you. So now I request our moderator for today's scientific section, Dr. Mandeep Kariwal sir, to take up the queries from the participants.
Thank you. First of all, let me congratulate Dr. Ali for a wonderful presentation. And I think the most important uh, thing that you're dealing with when you're dealing with cracked tooth is the detection and diagnosis. Most of us falter uh, diagnosing a cracked tooth. And once you diagnose it, then there are various treatment options that you can go and restore the tooth with. But initially, I think diagnosis is the key for success. So I have a few questions. There's
Yes,
a question from Dr. Megha. She asks whether the presence of a pulp stone is
yes.
every time the presence of a pulp stone means the presence of a crack, as pulp stones are also commonly seen in elderly people.
No, the answer is no. Not every time. This is I
Not
told
every.
you. This is a pulpal response to an irritation which has been occurring from the crack. The pulpal response, the caries might also give the irritation to the pulp. That may lead to a pulp stone. So the main factor which I told you to see that this is a proxy measure. It is not always. It may act as a proxy measure to see, or if you have a thing that this might be a cracked tooth, and you can see the presence of a pulp stone, you might tend to not rule out further the cracked tooth, or you might probe more, or you may see, or you may use certain aids for the diagnosis. So you have to keep in mind that this is just a proxy measure.
It is a
Not
response
all.
to irritation, basically.
Yes,
That
definitely.
could be
Yes,
because of caries, because of
yes,
nocturnal bruxism,
yes.
heavy occlusal forces,
Heavy
whatever reason,
occlusion.
it's just a response.
Right,
So it's just a response.
right.
And the next question is from Dr. Anil, and he asks whether the initial response to stimulus is from which fiber and delayed diffuse response is due to which fiber and why, and
A
whether
delta,
cold test is more reliable than heat test.
no. A delta fibers, they have, myelinated, they are the myelinate fibers, which we have already, we have learned in our dental histology classes, and this also, that they are the first, to take the stimulus to the brain. A delta fibers, they have more speed, they are myelinated, they can locate, they can give you the proprioception also that this tooth is affected. But when there is increase in the the better metabolic toxins or the presence of bacteria, they lead to the presence of substance P and calcitonin gene related peptide. These are the factors which sensitizes the deeper C fibers, unmyelinated fibers. You know, these deeper C fibers, what they will do is they will decrease the pain threshold. When the pain threshold is decreased, there is a chance that you might feel a presence of a lingering pain after you have an intake of a cold fluid. Initially, when you take a cold fluid, it's sharp shooting pain. In a snap, it goes away because of the presence of A delta fibers. Now the C fibers has also been stimulated because of the continuous inflammation. That leads to the excitation of C fibers and presence of deep lingering pain, maybe gnawing pain. The patient might complain that, you know, my pain is whenever I press this, I feel good. Whenever I release it, again sometimes the pain starts. These are type of the complaints with the patient's presence with to it. So C fibers, obviously they are later activated in the later stage, and A delta fibers in the earlier stage. And heat test, the reason cited for the cold test being more proper is the presence of the bacterial toxin which stimulates the A delta fibers. That is the reason which has been cited. Heat test again might require a more amount of heat to be delivered to excite those fibers, and we know that the sensitivity and specificity of heat test is always less. So a cold test confirms with the earlier diagnosis of the cracked tooth as compared to the heat test, I would like to say.
Okay, so I hope that answers your question. The other question is from Dr. Lekha, and she's asking whether Diagnodent can be used for diagnosis of a crack.
Diagnodent is a laser, but you know the problem with Diagnodent is the laser beam is focused in a very small area. I have used Diagnodent for another purpose, but I know that working of the Diagnodent at All India Institute, we have been having the privilege for using Diagnodent. But the problem with Diagnodent is the beam which is the beam which comes out from that small micro tip. It is very small, you know. And the second thing is, though it being a laser, it does not have that much of intensity to, you know, classify that to make distinguish between the light and the dark areas of the tooth, or transilluminate that the specific volume of the tooth. It has very small focused beam of the light. And I personally, I won't, you know, recommend using Diagnodent. Another option might be a good fiber optic light from a good delivery of handpiece. That will be a better option. And these curing lights, having a tip diameter of maybe 11 mm, which can, you know, illuminate whole buccal or lingual area of that tooth.
Similarly, now the next question regarding diagnosis again is whether the use of CBCT is helpful in diagnosis of these cracks.
So the answer would be like, CBCT, if you have resolution proper, lower, smaller voxel size, smallest field of view might give you a slice of CBCT having a presence of a crack. You have to be diligent enough, you have to be astute enough to, you know, search each and every slice, and the smallest voxel size is preferred, and smallest, you know, field of view. That might give a resolution because the cracks are way smaller than that detection limit.
So very fine cracks might not be detected,
Yes.
but if the crack is wide enough
Wide
to be
enough,
picked up by
it
a
is,
CBCT,
yes.
then you might.
Yes, if it is progressing towards a split tooth, you might find it.
Split tooth, yes.
Yes.
Only. This question was from Dr. Megha. The next question is from Dr. Asha, and she's asking whether what is your take on reduction of occlusal contact? Reduction of occlusal contact. I think she means occlusal adjustment.
Yes.
Is that something that we should be doing when we are dealing with the crack?
Yes, but I will like to stress one point here is you have to be sure that that was the specific factor which had led to the presence of a crack. The problem is we are not sure that only that factor was the responsible one. So yes, it might help relieve some stresses, but ultimately when there is a crack, you need to splint it. That is the final thing.
Okay. I think the last question is from Dr. Urvashi, and she asks whether the material of restoration play a role in decision making of the tooth in the treatment of a cracked tooth. Also, are there any indications for direct and indirect restorations depending on the extent of the crack, or are indirect restoration the best way to go?
Yes, there is no specific material indication as of now, because what a material can do is just seal the crack on its superficial aspect. It cannot penetrate inside the crack, and once we know that when it cannot penetrate, we need a proper material to hold it circumferentially. That is the best thing which has been provided by the full crown. The other aspect of providing a full crown is you will endanger the pulp once, it might happen that you will endanger the pulp because of the circumferential cutting. So what I will like to recommend, or maybe I will like to, I don't know, sir, you are in the better position to answer or maybe guide us, is whenever the patient has been detected with a crack and the crack is on the like roof of the chamber, patient having symptoms, we can do the root canal treatment and we can provide with the crown. You can go with the onlay, but there is a chance of ultimate pulpal progression or development of irreversible pulpitis in later stages. And the same thing you can grow with a full crown with a crack which is superficial. But what personally I believe, if the patient has had this crack, we know that if it is let loose, it will going to progress. So we need to splint it, and we need to splint it by the full crown, which will prevent the avenues of bacterial infiltration and give a circumferential hold. What I can suggest is you can discuss with the patients, you can go for a root canal and a full crown. But if you want a more conservative option, I think an onlay, indirect bonded onlay is the best material, like best option for restoration. If the patient is not willing for a full crown, if the patient is willing for a full crown, I think we have to go for a root canal and then a full crown.
I think what is also important is to stress upon the fact that we are only doing bonded restorations. We are not doing any other sort of restorations, whether it's approaching the pulp or it is before the pulp. So bonded restoration of any sort would be depending on the patient's choice, like you rightly said, the economic background and everything. So bonded restoration would be the right way to go, whether it's in the indirect form or in the direct form. And of course, if the crack is approaching the pulp, then the root canal is the right way to go. But by a full coverage restoration, that will prevent the crack from propagating further and splitting the tooth into two. I think this is a very interesting topic, and you've dealt with it very nicely. My compliments to you, Dr. Ali. And Dr. Shinoy also for putting up this wonderful 1 month of education-based webinar series.
Yes.
Yeah, it's very nice, and it's a very good effort. So I think we've done with the questions. There are no more questions. I'd like to thank Dr. Ali for a wonderful presentation, Dr. Shinoy and her team for this wonderful platform to give opportunity to everybody to listen to such diverse topics and also benefit from the discussion that happens thereafter. Congratulations to everybody.
I convey my regards to you, sir. Thank you very much for the kind words and appreciation. For my humble efforts, I would like to thank you.
That's very well.
Thank you once again to Dr. Azhar Ali, our speaker, and Dr. Mandeep Garewal, sir, our moderator, for becoming the part of this event and making it a success. On behalf of the Department of Conservative Dentistry and Endodontics, we would like to present a certificate of appreciation to our speaker, Dr. Azhar Ali, and moderator,
Thank you.
Dr. Mandeep Garewal, sir. It's a kind request to all, please stay with us for a few more minutes. We are also conducting Mask Kits, Selfie with Mask contest. So kindly send your entries for the same before 29th of July, as on popular demand, we have extended the dates. The details are on the screen, and we would like to show some of the entries which we received. So kindly send your unique selfie with the innovative ideas. Apart from the academic activities, we wish to highlight those individuals in our specialty who have enriched their lives with the other co-curricular activities. As we specialty have constellations of endostar in galaxy. Let's have a look at one of them. Today, we have our endostar as Dr. Darshana Devadika. She has done her bachelor's and master's from A.B. Shetty Memorial Institute of Dental Sciences, Bangalore, and having 20 years of experience. She is Secretary Women's Forum since 2007, conducting various programs in relation to creating awareness on health, legal, and financial matters for women empowerment. She is actively involved in various cultural and social activities. A diva, a singer, and a mentor are part of her multifaceted personality. She's a travel enthusiast and a passionate about cultural and national activities. Currently, she's working as professor, conservative dentistry and endodontics, A.B. Shetty Memorial Institute of Dental Sciences, Bangalore. Let's have a look for her extracurricular achievements. Congratulations, ma'am, for being the Ender Star. Now, at the end, I request Dr. Gauri Gillen to propose code of ethics.
On behalf of our Department of Conservative Dentistry and Endodontics, I extend heartfelt gratitude to our eminent speaker, Dr. Azhar Ali, for sharing their expertise on the crack tooth diagnosis and management. We would like to thank our chairperson, Dr. Mandeep Grewal sir, for sparing his valuable time. Thank you all the senior faculty members and participants for joining us today. See you tomorrow at 10 a.m. with a new topic on Facebook Live. Have a great day ahead. With your due permission, I conclude today's session and end the meeting. Thank you.